All right, like Dr. Pierce said, we're going to keep this very casual. We really don't have a lot of time for these presentations. So one of the things about this presentation is that I'm going to go fast. The reason for that is because you guys probably don't want to hear me. You guys probably want to hear Dr. Howell or Dr. Riddle, my brother. I'm nobody in this group compared to them. But what I'm going to do with my presentation is just tell you how I work up a colic when they come to us, when they come to me. By no means, this presentation is just telling other people how colics should be worked up. No, that's not the purpose of this presentation. The purpose of this presentation is for you guys to know how I think when a colic comes in. So the first thing, and actually I took this picture, I stole this picture from my brother. He does the same thing when it comes to the foot. A colic to me is like a puzzle. And I have to, when they walk in, I have to start putting everything together to see exactly what this horse has. Sometimes I'm not going to know exactly what that horse has at that moment. And most of the clients probably want to know, the next slide will be, what is causing that colic? What is the prognosis? What is the treatment that I'm going to put on that horse? And how much is that going to cost? As a client, that's what most of the times people want to know when they bring the horse to me. When I look at that horse, it goes back to that puzzle. It's like I have to put a bunch of things together to see what that horse really has. The first thing that I really, and that's one thing that when cases get presented to us or they get sent to us, I'm asking a bunch of questions, and the questions is because they really help me out to figure that horse as far as like, okay, how long this horse has been colicking, what this horse does for living. What is the signal? If I'm dealing with a pony versus a warm blood, they get different problems. They get different diseases. So that's the reason why I'm asking a bunch of questions. Then I start putting that puzzle together. It goes back to the physical exam, then the rectal exam, what typically a veterinarian does when they look at a colic. And I'm going to go through them one by one really fast because this, to me, this is the boring part of the presentation and I won't get to the pictures. The pictures, just as a disclosure, there are going to be some graphic pictures. There's going to be some horses that didn't make it, and I have pictures from necropsy. But at the same time, I think that it's important for you guys to see what happened when you don't move fast with those cases. I kind of already talked a little bit about the history and the signalment. Differential diagnosis. If you're dealing with a mini versus a warm blood, minis, for whatever reason, they get stones, they get small colon impactions. So when they call me and a veterinarian calls me and tells me, well, I'm bringing you a mini, I'm not getting tunnel vision, but at the same time, I'm thinking, okay, this is what I can have, this is probably what they did, blah, 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 all those kind of things. Management. I'm going to be asking questions like that because that's, if it comes to a displacement of the large colon, most of the times it's a change in management. Did they change the diet? Did they change what that horse is doing? Did they brought a new horse to the farm? Did they put that new horse right next to that horse? Anything that will stress or will change the routine on that horse can throw that horse off a little bit, get a little bit of a gas colic, and then we'll go from there. And then the medical history. I'm going to be asking what this horse, if this horse is a horse that colics every 2 weeks, if this is a horse that colics once a year. All those things I'm going to be asking, and some owners and some trainers, I don't want to say that they get annoyed by my questions, but at the same time, I have to know because I'm putting that puzzle together. I put at the bottom knowledge of all sedations. That to me is very, very important because sometimes if the referring vet gave ditomedine, if they gave butorphanol, buscopan, silencing, if the horse got ditomedine and he got it on the vein or the muscle, when he comes to me, he's sedated. So as a surgeon, sometimes you have a hard time taking a horse to surgery when the horse is not colicking. So the sedation history to me is extremely important as well when they bring a horse to me. Physical exam. The physical exam, again, it might sound stupid, but at the end of the day, it really gives you a lot of information. When I do a physical exam, I already kind of have an order. I start with my heart rate. The first thing that I do, I take the heart rate, because if I have a horse that walks in with a heart rate of 100, that's going to change. I'm going to approach that horse in less than 2 seconds. If he has a heart rate of 100 or 120, I will change my routine and I will go, okay, let's pass an nasogastric tube. If this horse needs to reflux, if this horse is going to rupture his stomach if I don't pass a tube. So the physical exam helps me a lot. Heart rate will help me out with pain, will help me out with dehydration, if the horse is toxic or not. And it's very useful for prognosis, because sometimes if you have a horse that comes in with a heart rate of 100 and you sedate him and you work with him for 10, 15 minutes, and that heart rate stays at 100, our odds are going to be pretty low as far as bringing that horse back. And those are the things that you guys want to know, because when you guys come to me, it's not, you want me to help you out as far as like, what is the right thing to do with this case? What is the prognosis? What is, should we take him to surgery? Is it worth it to take him to surgery? All those kind of things. Another thing that I do, I always take the temperature. Why? Because if you have a horse that is colicking, but he walks in with a temperature of 103, that actually slows me down when it comes to a horse, if I'm going to take it to surgery or not. If I have a horse that has a fever of 103, most of the times, those horses don't end up going to surgery immediately. They have something different. It will be anterior enteritis. They're brewing on colitis. So the fevers will help me out, the temperatures. Mucous membranes, toxic lines. I have a picture in there where it's pretty bright red. That's another one that tells me kind of hurry up as far as getting this horse stable, but think about it. Look at the horse. See what's happening. Do we have colitis? Do we have anterior enteritis? Don't cut this horse yet. Just look into the blood work. Look into all those things. Gut sounds, that's obvious. And another thing that I put at the bottom, because it has happened to me. Sometimes you have a horse that comes to you and says colicky, colicky, colicky. Sometimes they're not colicking, they have another problem. It could be to the lungs. So I will have a horse that I'm working as a colic and I can't find anything. I might grab that ultrasound probe and I might put it on the chest and see what's really happening with that case. And I have seen horses that you work him up, he's colicky, and then you put the probe in the chest and he got pneumonia. So sometimes we can be misled a little bit by the trainers, and not in a bad way. And that's the way that everybody's thinking, is colic, colic, colic. And you're thinking colic, 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 and then when you look at the horse, it's like, oh, there's something different going on here. The physical examination is very important for me, but another thing that I really, really like to do if the horse is stable is just to put him in a box stall and just observe. I think that, and I shouldn't be saying this, but I'm going to say it, you don't have to be a veterinarian sometimes to decide if the horse needs to go to surgery or not. You just put him in a box stall, and if the horse continues to colic, well, then you just have to take him to surgery at that point. There's nothing that you can do about it. So I'm very big. If I have a horse that is stable and I have done every diagnostic that makes me feel comfortable leaving that horse in the stall for a little bit longer and not in a rush, it's just to observe the horse. Around here, and I'm learning, I'm new in this town. Around here, I get a bunch of medical colics that come to me just for fluids and stuff like that. So clients kind of like that I say, hey, there's no surgery, let me just put him in the stall and let me just see how this horse is doing. And most of the time, we've been getting pretty lucky that I can get most of these colics just to get through, because they're at the horse show, and I want to say that most of the time it's just a simple gas colic that people got worried about it. They're showing their horses. It's 5, 6 o'clock. They don't want to be monitoring the horse the whole night. So what is the easiest thing to do? Send it to Jose. Jose has the personnel, and he will just observe all night long what that horse is going to do. I don't know why I said wrong. The rectal examination. The rectal examination, of course, obviously, it gives you a lot of information, but at the same time, this video is pretty good because, as you guys can appreciate, I'm a short guy. So I got short arms. So when it comes to palpating a horse, I have to be honest and we have to be realistic with the clients that I'm probably only palpating just the back 1/3 of that horse. So if they have a problem way in the front, I'm not palpating that. I'm not. That's just the reality of it. So this video is just basic video, just palpating the pelvic flexure, moving cranially to see if there's an impaction, then the spleen, the kidney, the cecum. Those are the things that I'm palpating when I palpate a horse. If the horse is gas distended, if I feel if there is a distended small intestine, all those things go back into that second slide where it's putting that puzzle together. And I put that at the bottom because most of the times if I do a rectal exam and I'm palpating small intestine, the small intestine is the one that I feel like you have to be aggressive sometimes when it comes to surgery. Because if you have a lesion in the small intestine, most of the times it's going to be a strangulating lesion. On those ones, you do want to be proactive because the longer you take, the chances of not being able to work that horse, wake him up after surgery or making the surgery a lot difficult for you has to do with the small intestine. I put that like nasogastric intubation. Again, this is, I think that they're basic stuff, but at the same time, I put them in this presentation because I think that they're extremely important. If you have a veterinarian that comes and look at your horse and does a quick physical exam, I strongly recommend you that you ask your veterinarian to pass a nasogastric tube. Even though just to chip the horse to me. And the reason why I say that is because if you have a horse with anterior enteritis or a horse that for whatever reason his stomach is very distended or impacted and you didn't pass a tube, then it comes to me and then I have a ruptured stomach, it's game over. There's nothing that I can do about it. So I always recommend passing a nasogastric tube. Sometimes if I have a veterinarian that is at the horse show and passed a nasogastric tube 10 minutes ago, well then I'm realistic. He came, they just passed the tube, I'm not going to pass the tube because they just did it. I have to respect my colleagues. I have to respect what they just did. And if I have a good relationship with that referring vet and they pass the tube, I'm going to skip that part. I got only 15 minutes, so let's move fast. Blood work. I think that is very important. I think that it helps you a lot with the prognosis as well too, especially for large colon volvulus. If I have a horse that comes in with a pack cell volume of 60 and a total protein of 3, that tells me that we're in trouble. And that tells me that the prognosis on that horse with surgery is still not very good. So there's been a lot of research that has shown that blood work is very, very helpful. Yeah, then the basic stuff, electrolytes, white blood cell count, total protein. Those are the things that have to go back into that puzzle. Abdominal centesis. This is where I'm trying to take a sample from the fluid in the belly. I tend to do this a lot because it helps me out a lot if I can sit on that horse and put him in a box stall, or if we have to be proactive, if we have to move really fast. The belly tap on a horse should look just like this, normal. If I get a belly tap that is this color, we're really putting a lot of effort in trying to figure out why this horse is giving me this or giving me that color. This is, to me, looks like straight blood, but if I get something that is like this, I start thinking that I have a strangulating lesion. And if I have a strangulating lesion and I have a horse that is not colicking, by me putting him in the stall, I could hurt this horse a little bit or just change the prognosis. So this is very helpful for me. It goes back to that puzzle. And this is the values that we're going to be looking at. We're going to look at the total protein, white blood cell count. If I'm sure that there's some veterinarians in here. I don't have to repeat that, but we're going to be looking at the lactate, and we're going to compare the lactate on the belly versus the lactate on the systemic, the one that we pull from the vein. We can look at the glucose, we can look at the pH, and when we have horses that we can't really figure out that much, we do run all those things, and we do look at all those things, because it might help me out to taking a horse to surgery or not. Ultrasound goes back to what I just said. I only can palpate 1/3 of that back end of that horse. So I like to use the ultrasound because then I can see 2/3 that I couldn't palpate. This ultrasound is just small intestine, 2 different diseases. If I see this ultrasound in a horse, I'm going to be thinking anterior enteritis versus this. I would just say this is more gastrointestinal. This one will slow me down a little bit. This one will get me a little bit worried and start thinking before I say anything to you guys. It's like, okay, how did I present this? Because we got to move a little bit faster here. So I like to use the ultrasound a lot as well. Now we're going to types of colic. This is where it gets more interesting for me as far as the presentation. I'm going to be able only to talk about large colon. I'm not going to be able to talk about small intestine today. If we don't have the time for it. If this turns out good and you guys enjoy it, then we can do this another time. Gas colic, that's the ones that I do not tend to see. Those are the ones that you guys tend to see. Those are the ones that you guys treat. Those are the ones that veterinarians at the farm get to see and they get to treat. That's the one that is going to respond to banamine. They can get pretty painful at the beginning. They will be going up and down, looking at their belly, and they will be colicky. That's the one that you most likely, or your veterinarian, will treat with banamine, buscopan, stop feeding that horse. And most of these horses, if you have a gas colic, and if it's a true gas colic, they will get better on their own, and then you don't have to bring them to the clinic, and it's a lot better. I do not tend to see those, or I did not got to see a lot of those in Kentucky. But down here, because of the horse shows, I do get to see a couple of gas colics, which is good because they make us look good. I'm honest. And then if you have a horse that has a gas colic and you treat it with banamine, buscopan, you sedated him, or your vet did that, and then an hour later he's colicking again, then I recommend you just put him in the trailer. You still might be dealing with a gas colic at that point, but don't run the risk of having something worse and then waiting until 10, 11, midnight, and okay, where's the trailer? Okay, I need a truck. Then you're going to delay 2 or 3 hours, and that can change the prognosis on the case. Large colon impactions. This is something that they do down here a lot because sand impactions. I'm sure that a lot of you guys have seen it, where we just do the sleeve to see how much sand there's present. And you can see the fingers in this sleeve is full of sand. That will change, or that will slow you down as far as like how aggressive you're gonna be surgery or not. This is just a picture of an impaction that, of course, didn't make it, it ruptured. It's the second most common one. The first one was a gas colic. The second one is the impactions. I don't get to see those that often. Most of the referring vets are gonna be treating those at the farm, just with nasogastric intubation and giving them fluids, giving them Epsom salt, giving them mineral oil, and giving them fluids. If for whatever reason they do it for 2, 3, 4 hours and it's not working, then that's when I get to see those. Same thing, they can be mildly colicky, they can get worse. Gut sounds are going to be decreased. Some of these horses can reflux, differential diagnosis. It will be a large colon displacement. But most of the times when you do a rectal exam on this, they're pretty obvious. You palpate one, they're pretty impacted. But then the question that you have is like, which one happened first? Does this horse has a displacement? And due to the displacement and a mild obstruction, I'm dealing with an impaction, or do I have a true impaction? So that could get tricky sometimes. I probably passed the 15 minutes already, right? All right, so how do I treat large colon impaction? The best treatment for me is going to be fluids. And actually, this is a tube that I have actually, it's a nasogastric tube, it's a small one. So I like to give these horses a lot of fluids into the stomach. Gastric colon reflex, it helps with impaction, is the best way to give the horses fluids, is the best way for your account as well too, because it's a lot cheaper than me doing fluids intravenously. If I have a horse that has been treated for the impaction with fluids by the referring vet and is not getting any better, then I do both. I do the nasogastric fluids and I do IV fluids. When they get to me, I have to be a lot more aggressive than what the other veterinarian was doing. Pain medications, Epsom salt, of course you're not going to feed them. And the prognosis is excellent. I rarely, 5 minutes left, I rarely take these horses to surgery. If I take them to surgery, they're impacted. Most of the times we do an enterotomy and we just have to empty them out. When you're dealing with a large colon impaction, there's always a risk in surgery. It's a very large bowel that by me exteriorizing it, I can rupture it. It can happen, that's the truth. So the ones that I'm going to take to surgery are the ones that you cannot control the pain, heart rate, for whatever reason, continues to climb, and the horse is just deteriorating. It's just not getting better. At that point, you have to make a decision with the client and say, hey, the horse is not doing well, the horse is getting more gas distended, we have to go to surgery. 5 minutes, we're going to move fast. Large colon displacement is a non-strangulating lesion. This is the ones that I tend to push it a little bit. I tend to put them in the stall. I tend to put them on fluids. I might add lidocaine, because what you want to do is buy them time to see if they can fix that displacement on their own. You have a question? No? They will be mildly colicky. You give them Banamine, then they stop colicking. You stop the feeding and they stop colicking. Then the Banamine wears off 6-7 hours later, then they colic a little bit again. So that's most common, that's like the large colon displacement. There's different kinds. There's the nephrosplenic entrapment or a left dorsal displacement. Since we have to move fast, this is normal. Head this way, tail this way. This is where the large colon should live. Is creeping up against the abdominal wall and the spleen, keeps going up, and then it gets entrapped between the spleen and the kidney. There's a ligament in there that, what do we do with those? I'm gonna run out of time. What do we do with those? If you are pretty certain that that's what the horse has, we tend to give them phenylephrine. It's just to make that spleen to get very, very small with the hope that the large colon can fall back into a normal position. Some people will ask you to roll those horses. I'm not big into rolling horses because it's hard sometimes to drop a horse in a short IV anesthesia, gets up and then he's still entrapped, then I gotta talk to the client again. It's like, I gotta drop this horse again. So I tend to, if the owner is gonna give me the opportunity to drop this horse, I'm aggressive. At that point, I wanna take him to surgery. I wanna fix it. If money is a concern, this is something that we can try. And it works. Sometimes it works, sometimes it doesn't. Can they happen again? That's one question that most of the people are going to ask you every time that you take a horse to surgery. This is going to happen again. Well, we're veterinarians, but we're not. We don't have a crystal ball. I can't tell you if it's going to happen again or not. We give you a percentage, but a client told me one day, I don't care about that percentage because if my horse colics again or he has another one, I'm 100%. And the client had a good point. So things that we do, closure of the space, we can pexy, suture the colon to the ventral wall of the abdomen. And then this is very drastic, resection of the large colon. Pictures, you can close the space with a laparoscope. This is the ligament, that's the spleen. laparoscopic instrument with a needle. You're just suturing that together to get rid of that space. A different way to do it is putting a mesh, and then you open that mesh, you put it against the abdominal wall here, against the ligament, so you prevent the large colon from going up and getting entrapped. Right dorsal displacement, the video is self-explanatory. What they do is gonna go all the way around. Same thing as a nephrosplenic entrapment. They're not that, they colicky, but you can control them with, not feeding them, giving them a little bit of Banamine. Large colon torsions, this is the ones that you have to be very proactive, because more than 4 hours, that large colon is not gonna make it. And if you have a horse, these are pretty obvious when you have one. And the reason why I say they're pretty obvious is because they're very, very painful. It's what I say, they are like a fish out of water. They're just, you cannot control them. Some pictures. This is one that you take to surgery, and of course it was strangulated, so it's not getting blood supply. This is the one that in surgery you have to make a decision if to wake this horse up or not. The owner has to understand that this large colon can end up like this no matter what, if I fix it or not. There's ways to, if the owner wants to be very aggressive, and I don't do it that much, is resecting the large colon. But resecting a large colon way up here, you're very close to the abdomen, and that's a surgery that is gonna be heavily, or it could get heavily contaminated. I guess that I gotta be done, sorry. That's another one. This is the good part, this is the pictures. Right dorsal colitis, ulcers, just to non-steroidals. That's the dorsal colon. The ulcer was nasty. We actually did fix that horse. Ultrasound, you're measuring the thickness of the intestinal wall. Of course, he didn't make it, but this is how they look when you take them to necropsy. I'm gonna stop there, I'm sorry. I'll try. Any questions? That's slide 20-something, and we have 70-something slides. What's your question? I'm sorry.
I mentioned the heart rate being elevated at the time when you start to worry and think about surgery. But what is the heart rate elevating as a result of the pain that the horse is in, or is there something else going on that's causing the heart rate to rise?
So the question has to do with the heart rate being elevated. So to answer, there's so many scenarios. If you have one, it's anterior enteritis. You have an elevated heart rate. You pass it 2. You decompress that stomach, then the horse goes to his heart rate back to 40. So then that helps you on the diagnosis. So you don't know at that point, I haven't done an ultrasound, I haven't done any of that, and had a heart rate of 80, I pass an nasogastric tube, he gets better, then anterior enteritis moves up on my list. If you have one that you do everything, and you have to wait on the blood work, sometimes it could be that they're dehydrated, that they can be toxic. Some of those things will help you out as far as the prognosis. If it's a large colon volvulus, and you do the surgery, and after you do the, oh, he already moved me. If you do the surgery, and from that large colon, and then it looks to the one that it was dying, that's the one that the heart rate, no matter what I do, is gonna stay that way. Then I look at my PCV and my total protein, and if my PCV is going up and my total protein is going down, I have to talk to a client that this horse probably is not gonna make it.
Can we ask you to finish or no?
Can I take more questions? All right, next person.
Can you finish quickly?
I'm done.